Dr. A. Thanks for doing the talk today. It's a special talk that I think it's important to understand how do we go forward by looking back. And I think understanding some of the history, I think, is super valuable. And obviously, you've lived so much of this. We're so blessed to have you part of our program, and take it away.
Thank you very much, Greg, and good morning, everyone. Just to clarify, the topic was, I changed, this topic was the first on the program, but I was thinking about San Diego, but then I came to understand that there was a little bit more than I could do it in short time. So I talking about the history in general, obviously it's hard to do it in a short time, but I just touched to the some of the important points of evolution of spine deformity, and we can then talk about the San Diego influence later on. These are my disclosures. None is. And I think the importance of history is very is known, and really, if we don't really know the past, it's really hard to progress in the future. And this is a quote from Ted Billard. I did my fellowship in 1975 under these gentlemen, and John Lasting just joined at that time, and that was the year that I first went to SRS meeting, and that was because of the kindness of my co-fellows that was supposed to go, and I really saw that I am really interested and allowed me to go there, and since then I've been there every year. That was in Louisville, Kentucky, when Dr. Lederman was the president, and that was Ed Simmons was the past president, and Bob Winter was the upcoming president. So and this was in 1976 with Dr. Blount. As you know, is really the creator of the Milwaukee brace, and now that we have a Blount Humanitarian Award, that with congratulations to Greg Mundis, he's the recipient of this year in the Academy. So that is Dr. Blount in 1976. So I think my, describing the history of evolution of spine deformity really is parallel to what I lived in Scoliosis Research Society. And in the 50th year of the SRS meeting in Minneapolis, we decided to have a history exhibition to have a timeline of both history of SRS and history of evolution of spinal deformity. And I encourage everyone to sort of go to the SRS website, and you can have a virtual tour which has all the, and this is a sort of a ongoing timeline that will be updated constantly. This was the exhibition with all the things that went on since early on to current at that time, 2015, and now is again it's updated, and you can see all of that in the website and get some of the details. And each period and each decade has their own things with some of the artifacts and some of the information that is really interesting to go through. Also, you can refer to this paper that Pat Costiel and Hazem and Mark did, and it's about 3 years ago. So I'm just going to do it together with SRS history. So we talk about the pre-SRS, which is really going way back, birth of SRS, and then 60 years of SRS, and what to expect in the future. We all know about the Hippocrates and the word of scoliosis, the casting, different bending casts has been done over the years, and this was not too far. And during my internship and residency, we put the Trenberkel cast. Patients were in the hospital for 6 months or almost a year and gradually corrected. And once it was corrected, some of the patients were operated through the cast like this. You can imagine the dressing and draping of these so important. And then again, Milwaukee brace was originally done for post-operative immobilization, and then gradually became. And this is Walter Blount sitting, and Milwaukee brace was really the standard for years. Halo traction or other tractions are always used preoperatively and sometimes postoperatively. And internal fixation was different people, the Wilkins, harder than different one, from some wires to implants and to rods, or from early, late then 80s, 1800, and the beginning of 1900. Those are being used, but very sporadically. We all know about the Hibbs and fusion. He did the first fusion for tuberculosis, and then later on had fusion for scoliosis cases in about 1914. Some people, say that the first scoliosis fusion was from Canada, but nevertheless, the fusion started without that much of fixation in early 1900. Those days, between 1940 and 1950, there were two giants of scoliosis. In the West Coast was Risser, and the East Coast was Cobb. And they really were working independently, and really there was no communication between these two. Cobb, Joseph Risser, was in Los Angeles and was doing pretty much casting as well as later on in internal immobilization with Harrington. And this is, as you know, the Risser sign and measurements. It was done by Risser, and on the East Coast, John Cobb was reported on the result of surgery in 363 patients with a variety of bone graft types, and as you know, the Cobb angle and Cobb elevator and so on. But a lot of people, like Alberto Ponti, when they came to U.S. to learn, they had to go to each center, and they were just very humble to listen to the ones that are really were not really as friends. John Moe was pretty much the first one who really mastered the fusion with facet fusion and started the scoliosis clinic at Gillette at St. Paul and in Minnesota, and really was the one that uh, 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 popularized the fusion. And at the time when Harrington started to have the um, introduction of the Harrington instrumentation, he was the one that really joined with him and encouraged him to do fusion, so there would be less implant failure. They consider the kind open-minded, and I don't know about kind, but I think he was very open-minded, and he was listening to medical students, residents, fellows, and obviously he was the founder, one of the founders of the Scoliosis Research Society, and the first president for the first 2 years of this of SRS. These are one of the first papers with pseudarthrosis in AIS in 7% and neuromuscular 14%. And he was really the first to recognize the flat back caused by Harrington instrumentation and developed the Mo modification, which was a square end hook that could sit and prevented rotation, which caused flat back, and this was allowing to have some lordosis in the lumbar spine. So this was one of the cases that he had. This case of scoliosis. It was done in 52. This is preoperative X-ray, and it was done through the cast with just fusion, no instrumentation. And this is 1956, and 4 years after. And this is 25 years follow-up that really didn't change. No instrumentation, just the fusion. So the fusion worked, but obviously had a lot of discomfort with the cast being in bed for so long, and then mobilizing in the cast, which sometimes went to the, it initially went to the neck in the walking cast. So it was not until late 70s that the casts were underarm. Then Harrington developed a new approach using hooks and threaded rods. And it's interesting that the first he put implants in the convex side of the curve, and then added the concave part of the curve, and had you can see the flat back. This is basically a Harrington instrumentation with distraction on the concave and compression on the TPs on the convex side. Mark Asher is credited for really I'm getting crazy here. Yeah. Mark Asher was the person who really worked hard and brought the Harrington archives and Harrington material to Kansas City. And he worked about 4 years to study the development of, not only the development of the Harrington instrumentation, but the character and the personality and the history of Paul Harrington, and put that, published this book in Target Persistence that I really recommend, not only for professionally, but to understand Paul Harrington as a person. This is available, and very interesting book. Obviously, Mark passed in a few years ago. It was interesting. The work of Harrington really probably was the cause and this is a quote from John Hall, the second president, that's really interest was led directly to the formation of the Scoliosis Research Society. Development of that was that's very interesting for another time. How SRS was formed. David Levine, who was a resident at the time at HSS, was given the task to go to this continuing education course in Minnesota that Dr. Mo had. And at that time, he was really in a bus with Vern Nickel, who, with Jackie Perry, sort of developed Halo, and later on actually came to San Diego. He suggested to Dave Levine to propose to have a society, and he did. And Harrington supported that by giving $1,000. And in the next year, we had the Scoliosis Research Society in 1966, the first meeting. These are the 37 founders of the Scoliosis Research Society, with Jacqueline Perry and Dr. Mo in the middle. So when you talk about spinal deformity, really, we talk about the early onset, adult, and then AIS. For years, Scoliosis Research Society was really particularly or specifically discussion on AIS, to the point where at some point they said, well, we don't really need a society. We know everything about AIS. But so really, they didn't think that adult really requires any surgery. And when the first meeting, I remember, was I think in Canada, talking about the adult by I think it was John Kostwick or another presenter. Which is why we don't really, why we are doing surgery in adults. Early onset was really the really behind, and it wasn't until the past couple of decades that early onset came to the view. So I think that also shows that how focused we were really from AIS to adult and then to early onset scoliosis. Some of the things that appeared and then disappeared was, for instance, electrical stimulation, which really was very popular as a non-operative treatment, and then was many studies, including ours, that found that really is not effective if you do it on very progressive patients, if you really work on progressive patients. Spinal cord monitoring was really a brainchild of Les Nash, who was also a president of the Scoliosis Research Society, and there would be a bio on him in the next few months at the spine deformity. And because of him, there really was a foundation for spinal cord monitoring, his presentation and his work in Cleveland. Really, the segmental instrumentation started with Eduardo Luque. Luque was a surgeon, who trained in Los Angeles by Joseph Risser, and later married his daughter. But when he went to Mexico, it was really hard to keep the patients in the cast, and started to put sublaminar wires in the rods and just leave them without the cast. And I remember the first presentation was in, I think, 1976 in Canada. I think it was, he presented with all these blue slides, and everybody came out and thought, oh, he's crazy, putting all these wires every level. But basically, this was, the way that even corrected some rotational deformities and started the concept of segmental fixation. Um, uh, Again, the next step was Cottrell Debussy, John Debussy, who just passed a few months ago. Um, uh, really developed this concept of correction of the rotational deformity, and his logo was no cast, no brace. He was here, I think, in San Diego in 1989, and did the surgery at Children's Hospital. We were just observing, and then later he came to St. Louis when I was there, and really popularized his technique, and uh, that was probably the change between uh, uh, the work of Luki and and um, uh, Harrington. This is the CD instrumentation. Pedicle fixation is the first time was by Boucher, who really went from the inferior facet into the pedicle, and this was the form of that. Uh, Roy Camille really was the person who uh, uh, developed this, more further in France, and then Art Steffi obviously was the one that popularized it in the U.S. And this is the Art Steffi with pedicle screws. Bob Winter, Bird, and Puno developed the PWB system, but they really were the first to develop the first polyaxial screws. And then obviously, Dr. Suk in Korea really popularized the thoracic pedicle screw fixation, which was another jump in segmental fixation and correction of the thoracic spine. Jasinski and Harms introduced transforaminal lumbar interbody fusion, which added to another method to develop the fusion. Osteotomies, you can go and talk about them for many times. Smith Peterson, which and then obviously PSO was pretty much done by give credit to Tomlinson, and anterior fusion by Hudson in Hong Kong. These are all the techniques and methods that from different parts of the world contributed to the enrichment of spinal deformity surgery and care. Instrumentation anteriorly was done McDwyer from Australia, and then Zilke in Germany, and developed the solid rods. And I know I did the first case with him in 1977, invited him, and he was very German type surgeon, and he did all these approaches, and this is the solid fusion that you can do for this Linky 5 case. But this was very small rods, and then this sort of were so the other things from San Diego actually was by Peter Newton when he started to work on release of the anterior release of the spine combined with the posterior instrumentation and so on. And that was worked through the basic science, and preclinical work, and then clinical work to do the fusion to release in the discs. These are examples of it, which did the accident correction as courtesy of Peter Newton. But over the years, you can see the 15 years follow-up, he really studied them, had the good records, and then they released, transformed to instrumentation, and then the flexible tether came, and now this is the instrumentation, and tether is basically now is being investigated, and yet to be seen whether how things are for the young patients. Growing rods were developed and really replaced the previous Harrington instrumentation without fusion. The vector was developed by Bob Campbell for thoracic insufficiency syndrome. Basically, allowing the ribs to open up and create some space for the lung to breathe. So this was actually from before of about tethering, which I think it's been studied by Harm's study group, and really looking at the details of whether for instance it's really working in the thoracic spine or so it's ongoing research on this. You can see it's very good results here from Peter's case. And here is the MCGR that was developed here. Another jump in the treatment of really small children. I think we have many milestones. Anesthesia. I think it's not just instrumentation, but all of this really helped the treatment of spinal deformity, improvement in anesthesia, antibiotics, imaging, bone graft and fusion, biologics, instrumentation, spinal cord monitoring, and these are all really helped the treatment and care for spinal deformity patients. New surgical techniques, motion preservation, navigation, MIS, and use of AI. I think these are all things that are coming in the future. Imaging is really has helped to understand the three-dimensional deformity of the spine, and I think has been the base for a lot of understanding of the spinal deformity, especially in adult and both in children. A few slides that I have from Jay Kumar, who was very interested in history, and he's now appointed as a member of this historical committee. So I'm just putting his slides. This is all for the future. For the past 10 years, I have not been doing surgery. So I'm showing some of his slides that what is going to happen and what is happening now with modern instrumentation that you can see. Innovation continues, all the things that I mentioned and you all are facing every day, role of robotics and navigation, and personalized implants, for the patient-specific metal alloys, coming up, implants informed by AI. But those are the things that I'm sure, especially the younger guys, will see in the future, and things have been very different and is going to progress very rapidly, comparing to Harrington that used his technique, investigated his technique for 7-8 years, and then last for 25 years. But these are not going to be in the future. But whatever we do, we should not be thinking about the triumph of technology over the principle. We always remember our motto: first, do no harm. And this is from J. Kumar's time with co-fellows and the faculty. And I just stop here and thank you for your attention. Sorry, I went a few minutes over time.
That's awesome, Dr. A. Thank you. I was gonna actually ask you, like on the timeline thing. So you had like the one paper of Cobb's that was like 363 patients. Like, how long did it take him to get 363 patients? Do you have any sense of like over what period?
I think I know it was less than 10 years, but I don't know exactly how long. I have to go back and look at the thing. But I have a sort of few pages that Bob Winter sent to us on Cobbyism, and it's interesting. I'll send that, and he was the one that really pushed on having these Kapner gouges, wooden gouges, because he didn't want to hurt the spinal cord. But I don't know about how long did it took for that patients. But as you know, Harrington was the first one to really started to have computerized data in SRS with all those real, things that would fall in, and it was a, and then John Lastin, started to continue on that. But I don't think those were at the time of Cobb. So I don't. Oh, that's a good question. I'll look at.
And then, what do you think of like the role of the burr?
Roll off
the burr for
burr?
decortication.
I think that came.
Because
No.
how were they decorticating back then? Were they using mainly rongeurs and osteotomes?
Yeah, there was no power. Was not allowed. The same thing that cast saw wasn't allowed to cut the cast, and we had to do it with the knife. It was all gouges and trying to get the cortex and get to the bleeding bone, and then use that as a bone graft, put it in the facet joint, take the cartilage out. But there was no burr, and we were not allowed, and we were not really having the safe technique to do that. It was not until past 2 decades that really the motorized things are done now. It was all gouges and special mallet, getting decorticating. And the thing was that we had to even not only the gouges, but the Cobb elevator. There was a lot of this dissection was with the Cobb elevator. So you had to be sharp, and it had to be, as a resident, we had to sharpen it before every case. So because then Cobb elevator was, if you had the right motion, you can take the muscles through between Cobb and the lamina, and so you don't have to, and then you can see where the bleeding is, and cauterize it before it bleeds. So so the Cobb and the gouges is all hand driven instruments.
Monster forearms. Well, thanks, Dr. A. Appreciate it. Anyone else have any questions before
Thank you for everyone.
Sign off?